We're going to be talking about pediatric foot. I have a few consultants. They're all spine stuff. Until we start putting spine rods in feet, it won't impact this talk. So there are some common pediatric foot deformities, and there are others, but I thought we'd talk about them. So club feet, Metatarsus Adductus, calcaneal valgus feet, rocker bottom foot, which is different, flat feet, which is kind of everyone's the bane of their existence, Tarsal Coalition, and finally Cavus feet. So let's start with congenital clubfoot. So a congenital clubfoot is a severe deformity. Oops, sorry. Where's the, here we go. A severe deformity characterized by rigid equinovarus posturing of the foot, which is different than the positional clubfoot, where it looks like a clubfoot, but you can actually straighten it out. All right, the way to remember the clubfoot is the mnemonic cave. The foot is in cavus, it has a high arch. The forefoot is adducted. The heel is in varus, or tilted into the midline, and the foot is pointed downward, or in equinus. There's also supination. There's some deep creases occasionally in the middle of the foot. You guys have seen that, or posteriorly. And the whole leg could be spun medially. The important thing to remember, this is not an isolated foot deformity. This is a hypoplasia of the limb. For the rest of their life, if it's unilateral, they'll have a smaller calf and a smaller shoe size, sometimes several sizes. We don't know what really causes it. More and more, it's becoming clear that there is a genetic basis. A little loud, sorry guys. Genetic basis for clubfoot. And what's interesting is we don't think it's really external pressure. If you really look, the talus bone is abnormal. There's a lot of bony abnormalities. Even when you correct the foot through surgery or through casting and it looks great, the calf is smaller and the foot doesn't grow normally. So there's something intrinsic about this. All right. So it's common, right? About 1 in every 1,000 live births, and there's a multifactorial inheritance as we suspected. So if mom had it, there's a 2% risk that the babies will have it. Second order relatives, there's a little bit, 0.6%. So it is definitely genetic, but it's not a complete penetrance, okay? And about half of these are bilateral. So what is our goal for treating club feet? Well, we want a flexible, shoeable foot. And I think the trend has switched from surgery to try to put every bone in the right place and all the angles to be perfectly correct, to casting, where that may not be exactly true, but the foot works great, looks great, is flexible, and we don't have the stiffness from surgery. So treatment options are Ponseti casting, which we do most in this country. The French have a physical therapy guided daily stretching program, which so you have to drive the kid to the hospital every day. The French have reduced work hours now, so they probably don't work enough to do this. So we'll just talk about the Spanish, like Dr. Ponseti, very hardworking people. So we'll talk about that. So this should be started as soon as possible. Now, when my wife was studying for her boards, she was doing a review book, and the options for a question about a child with clubfoot was refer for immediate casting the same day or have come to the orthopedist in the first week. And the answer was the same day referral. I stopped myself from writing to the company to refute that, but that's not actually the case. Casting a child at a couple days, I'm going to lower this more because I hear myself. You guys can all hear me? Okay. I usually don't need a microphone. Even within the first several weeks, it can be effective. In fact, there's a very active program through our society for developing countries where some of these kids are 2 or 3 when you start casting. That's not ideal, but clearly, letting the parents go home, especially the first child, they're figuring out, how do I put these diapers on with an umbilical cord still there? It's really too much. So they go home and they see us within a couple weeks. We manipulate the foot and cast it weekly. The last thing we fix is the equinus, and that's often due to a tight heel cord. So if that's the case, about 90% of the time, we put a little Elmla cream on the heel, and we actually cut with a beaver, a little eye scalpel, in the office, the Achilles tendon. And then we put a cast on for 3 weeks. It heals completely, which is amazing. And they go into braces afterwards. If you look at the display table, our 2 sponsoring orthotists both have examples of these braces, so I'd advise you to do so. It's a shameless plug. So this is what it looks like. You have the inverted foot, and then serially we change the cast, slowly bringing it around and then finally up. And then they wear shoes like this, or a fancy version, full time for about 3 months, and they wear it at night till they're 3. The #1 reason for recurrence is poor compliance with the bracing. All right. So if that doesn't work, or if a part of the deformity recurs, they need surgery. We usually wait till they're about walking age. The results are better. And we have to cut all the way circumferentially around the foot, disconnect all the joints, we pin it all together. So we can get the foot to look pretty nice, but it often is stiff after surgery. And there still is a chance of recurrence. So we have to follow these kids for quite a while. So clubfoot is rigid as opposed to a flexible deformity. Now there are some times where you see these kids where you say, you know what, I can kind of correct it, but it's just still a little bit stiff. I do cast those kids. Occasionally, 1 or 2 casts will straighten that out. So a lot of times there's that kind of question point. It's not really a club foot, but it's not a normal foot either. I wonder if I should refer it. I think if it can't overcorrect, it's not super flexible, it's worth taking a look at. And again, casting is the first line treatment. Also be aware, as we all know, many other syndromes will have, tethered spinal cord, spina bifida, arthrogryposis, will have club feet. So be aware of that. Look at the whole baby. We really try not to operate if we can avoid it, and we have to keep an eye on these kids for a long time. All right, so this is like clubfoot light, right? Metatarsus Adductus. And this is another thing, where parents get very concerned and worried about this, and it's helpful to have an algorithm. So how do I refer these? So if we look at the bottom of the foot, all right, we have the mild foot. So if you stroke the side of the foot or tickle the foot and the baby fires the muscles, they can evert on their own. And when you go to stretch it, you can overcorrect it, all right? A moderate foot would be defined by one where you can kind of get it straight, but it takes a little bit of stretching. And rigid, which is pretty uncommon, all right, should be one that you really can't correct at all. So how do we treat these? Well, the mild ones, I tell parents, listen, every time you change the diaper, you show them how to hold the heel and stretch the forefoot and do this every time. Whether that really helps or whether it makes them feel better or both is unclear, but in reality, the natural history of that is fairly benign, as opposed to the other ones where we often do casting. And what I see often is, you guys see, probably, 20 kids a day as parents begging you to refer someone for their Metatarsus Adductus. And most of them are really mild. But some of them persist, and the parents stay on it and stay on it and stay on it. And finally, around a year, you say, you know what? Didn't really go away. That's right, we should refer you. It's hard enough to cast a 3-month-old. They're big, chunky, they fight. It's next to impossible to cast a 1-year-old who really doesn't want to be casted. So what I would say, and I maybe will regret saying this, but I would almost rather these be over-referred. If the child is 3 or 4 months old and it doesn't look like it's getting better and it doesn't look like it's super flexible, it's worth a referral because often 1 or 2 casts, and then they have all kinds of special shoes and things that will hold it, can take care of it. And what you don't want is the 10-year-old who doesn't make the competitive soccer team, and the parents say, it's because that foot, Dr. Smith, I told you we should have sent someone to have a look at this. So in reality, we're not really sure long-term whether there's any issues with this, but we do cast them occasionally, so if they're under 6 months, it's something to think about. All right. Now, moving on to positional deformities, the calcaneus valgus foot, and you guys know this can look horrifying. The tibia flat pressed against the tibia with the heel, the foot flat against the tibia with the heel pointed downward. All right, the foot often looks long and skinny. This is pretty straightforward. You have to rule out a couple things. So a posteromedial bowing, this is a kid actually I saw not too long ago in our clinic. He was an African child who was sent in for evaluation of his clubfoot, because everything is generically a clubfoot. And you can see he's got this bowing. It's not the foot, it's the tibia, and that's his x-ray. So make sure it's not the tibia that's bent, okay? And also make sure the child is neurologically normal. A child with spina bifida that has L4 function so they can dorsiflex their foot, but they don't have any plantar flexion may present that way. Normally the spina bifida, the finding is not the foot, but the giant open spinal cord in the back. But, if you haven't gotten that far, always be aware of that. All right, so what do we expect? This gets better, all right? Again, this is a stretch with diapers type thing, all right? And I will tell you this day, and I don't know exactly what the issue was, but my mother, and my wife will corroborate this, swears that I had horrible crooked toes, but that pediatrician told her to stretch that toe every time she changed the diaper, and I have wonderful toes today. So parents do remember that, and they like doing it, and it can actually help this resolve more quickly. If it doesn't go away by walking age, figure out whether or not you have the right diagnosis. Maybe this is neurologic, maybe there's something else going on, all right? Such as congenital vertical talus. So this is not very kind. Who's seen a congenital vertical talus? Anybody? Okay, so not super common, but we certainly see it a fair amount. And the difference is this is a fixed rigid equinus. So the heel is not pointed up, the heel is pointed down, and the foot bends in the middle. And it can do so because the navicular bone is dislocated. The middle of the foot is bent in half. When you see this, the first step is the genetics referral and the thorough examination, because the majority of these are associated with other things. Not always, but this is, as opposed to club feet where you got to think about it, this is, we really have to look at this thoroughly. So things like spina bifida, like this child, arthrogryposis, prune belly, SMA, neurofibromatosis, or any of the trisomies, all right? We don't know what causes it. It may be a muscle imbalance, like in spina bifida. It may be an arrest of fetal development. It may in some way be from intrauterine positioning, although that seems less likely. All right? You can see it on ultrasound. And again, there's a convex plantar surface. The Achilles is tight. So as opposed to calcaneal valgus foot, it's going down. And the foot is in valgus, externally rotated, and the tendons are super tight. Okay? And this is what it looks like. All right. So if you look at the bones, here's the talus bone pointing straight up and down. And the navicular bone, which is supposed to be here, is sitting on top of the neck. All right? And as opposed to calcaneal valgus, where this calcaneus now is pointed downhill. All right? So in an older kid, it can look like a flat foot. All right, so look at this kid. This is a vertical talus. This is a normal foot. And you see it doesn't look as dramatic as that other picture. All right, so what's the differential of this? How do you tell? Well, here's the calcaneal valgus foot where the whole foot is pointed up. Here's the CVT where the back of the foot's pointed down and the front is pointed up. All right, this is what the x-ray looks like. Here's a normal foot. Here's the talus. When the foot is in forced dorsiflexion, and we do this in the office, right? The whole foot lines up and the calcaneus is pointing uphill, all right? With a CVT, you dorsiflex the foot, the talus is pointing down, the calcaneus is pointing down, there's no angle between them, and the rest of the foot is pointing up. If you look in plantar flexion with a regular foot, the first ray and the navicular line up with the talus. In a CVT, the talus still points down and you just bend the rest of the foot. Okay, so there are some reports of serial casting being helpful. That's really not widely accepted. This is a surgical problem. And again, we have to cut all the way around the foot. So here's a kid that I took care of with a vertical talus that was pretty significant. You can see the verticality of the talus. Here's the first metatarsal. When I bend it up, one is still pointing down, one is pointing in another direction. And then we open the whole foot up. You can kind of see the air in the soft tissues. We line everything back up and pin it together. So it's a surgical problem. Okay. So that's a vertical talus. And again, the take-home point of that really is, if it looks like a rocker bottom foot, make sure there's nothing else going on, because there's a high association with neurologic problems. So flat feet and things that we call flat feet. So what we don't want to miss, the lifelong crippling disability from those evil flat feet. All right, in reality, painless flat feet often don't cause problems, right? And I love this picture. I didn't realize this. Flat feet can cause, like, literally even your brain is affected. So this is out there. All right, so it's common. We can think of it as a normal finding in most small children. And the key here, because we see all types of this. Some docs say, you know what, I'm not going to refer flat feet, but maybe some should be referred. Other docs, come to a meeting where one of us says, oh, flat feet never matter. And that's irresponsible. They do matter sometimes. So we have to distinguish a flexible flat foot from a rigid flat foot, an asymptomatic flat foot from a painful flat foot. And if we're treating them, we have to decide what the goal is in our treatment, okay? So a normal arch isn't present, but it develops over the first 4 to 5 years. These are the kids that they sit on the table and their feet dangling and they have a nice arch, then they stand up and you wonder where it went, all right? So this is a kid, I should have cleaned the floors in my office before I took this picture with my phone, but this is a child that I saw not too long ago. The little kids, what do they come in? The referral's not flat feet. The parents say the ankles are turning in, right? You have this medial sag of the ankle, right? Valgus of the heel. Now the kid stands on their toes and the arch reconstitutes nicely. When the posterior tibial tendon fires, it pulls the arch up. When it's standing at rest, it doesn't. So you have these kids stand on their toes. You have them walk on the lateral border of the foot. We'll talk about tarsal coalitions. They can't walk on the outside of their foot with a tarsal coalition, and that's the cause of a rigid flat foot. We check the range of motion of the joints to make sure it's full, and we do a quick spine, gait, neuro exam to make sure this is not part of a bigger picture. All right. So a flat foot, and I tell parents, this is, in my mind, this is a flat foot. So when an orthopod says flat foot, he means not so much the arch, but this other stuff. When you look from the side, from the back, too many toes. You look at a normal foot, maybe you see the pinky. In a flat foot, you see too many toes. The midfoot sags, all right? And in some kids, we've all seen this with connective tissue disorder, that thing's on the ground, right? It can be dramatic. They can get a callus over the talus, right in the arch. Instead of having an arch, that talus is right on the ground. And the lateral column is relatively shortened. So this side gets stretched out, this side looks shortened. All right, this is the Jack test, right? Pretty much everyone would refer this thing. This looks awful. Look what happens when you pull up the big toe. Whoop, get the arch forms. So you certainly can see dramatic flattening in a flexible flat foot. So the differential, okay, is a vertical talus, and I showed you that picture of that older child, right? Tarsal coalition we'll talk about. These kids with a neurologic problem get a tight Achilles tendon, and in order to get their heel on the ground, they break their midfoot. They flatten out their foot so their heel can get on the ground. Accessory naviculars we'll talk about. Occasionally kids with JRA will have subtalar joint involvement and they'll have a rigid flat foot. And connective tissue disorder. I've seen many, many kids that I've diagnosed with Ehlers-Danlos, or I should say I've referred to Natasha Schur, and she's diagnosed with Ehlers-Danlos because they present with really horrendously flat foot, way flatter than you think they should have at that age. So it can be subtle, but important to remember. So what's the natural history? Again, flat feet only kill you if you get them by jumping off the Empire State Building. So in the first 8 years of life, this will spontaneously improve. Harrison Beath did a study in the 40s. They took over 3,000 Canadian Army recruits and had them answer questionnaires about foot symptoms, looked at stress fractures, et cetera, and they couldn't find any correlation between flat foot and having injuries. Okay, so what do we do with the kid who has a flexible flat foot? Well, often a chicken or the egg, whether it causes the flat foot or whether it's a result of the flat foot, the Achilles gets tight. So you have them stretch. You don't have them stretch with the foot everted, which just accentuates the flat foot. You have them turn the foot inward a little bit and then stretch off the back of a stair, okay? The role of orthotics, there are podiatrists in town who send me kids with orthotics when they're 2. And I think that I understand the concepts, and clearly this looks better than that. On the other hand, $300 that you change every 6 months as they grow for 18 years seems excessive. So what we know is that Denny Wenger, look at this, he's a guy in San Diego. I tell parents, we can do fetal surgery and implant arch supports in the womb. You will still have flat feet as an adult if that is your destiny, okay? That being said, it doesn't mean I'm anti-orthotic, okay? The kid with pain, with symptoms, can be given an arch support. I tell them to go to a running store, go to a drugstore, get a pair of Spenco or Dr. Scholl's or any of these cushioned arch supports, start with that. If that's unsuccessful and they really have a lot of issues or they're having a lot of knee pain or other things that you're chalking up to this arch, then they can go ahead, and we have a great podiatry group in town. There's several great podiatry groups in town who really make a nice molded custom orthotic, and we can do that. The brace shop down right below our office, and some of the guys in the community as well often will do this for us. So we will do this, but I think the first step is to try something simple and not just treat it, because if we don't treat it early, it's going to go away. Treating it early is not going to make it go away. And that's important, all right? So when the parents hear the womb thing, they feel better because what's your worry as a parent? If I don't do this now, on her wedding day, when her feet hurt in her high heels, she's going to say, Mom, why didn't you take care of my flat feet when I was a kid? And so you can tell them because I didn't have to. So rarely, I don't know how many kids for flat feet, a couple times a year. In a busy year, I'll do 3 or 4 of these surgeries, okay? We cut the lateral column, which again looks short. We swing the foot over and stick some hip bone in there, and that will reconstitute the arch nicely. We don't know that really works. It works in the short term. We don't know that it's going to be better than doing nothing in the long term, all right? I mention this because when I was a fellow, Dallas Podiatric Association took out a huge ad in Dallas Child magazine. We have similar versions up here. Fixes the, and you go on the internet, they jam these things in the subtalar joint, and there's a whole article by this well-known podiatrist about how if you do it in little kids, it fixes the problem, it cures flat feet, you should do it immediately before there's a problem, and they're operating on small, small children, all right? To me, taking a metal thing and jamming it between the bones and the foot doesn't really seem like a great solution. And when they used these silicone pegs, you don't see them on the x-ray, which is good. They break, they cause a giant cell reaction, spurring. So every once in a while, a kid comes to my office saying, I saw Dr. Schmitty or Dr. Jones, and he said that we should do this thing. What do you think? And I say, you know what, I don't know everything, certainly. My wife will verify. But in reality, I would never let someone do this to my child. That's personal bias, and I think that's supported by the literature. So it'll be out there. They're going to ask you about that. What about this plug? It's a tiny incision. They put a wire in. Go home the same day. It's great. I wouldn't do it. Okay. So what's not okay? All right. Painful flexible flat feet. So the rare normal child or the child with connective or collagen vascular disorder, right? The accessory navicular and rigid flat feet. Vertical talus, CVT, talked about that. Tarsal Coalition, we'll talk about that. And JRA, again, that's beyond the scope of this, but be aware that this can be a sign of an inflammatory condition. Okay, so this is a accessory navicular. So unfortunately, I made this black and white for a book chapter, then couldn't find the original. But if this were in color, you would see redness here. And you can kind of see how the skin is thickened. And this is an accessory navicular. There's 3 types. It's either a little ossicle in the tendon, it's fused to the bone, or the most common, it's got like a little bridge between it. So both because there's a cartilage bridge that wiggles, and that hurts, and because it's prominent and the foot tends to be flat, the kids have pain. All right? They have pain right there. So when they come in, they say, my flat feet hurt, and they can point to the spot, that's an accessory navicular, 99% of the time. And you look really smart when you go, I bet you have an extra bone in your foot, and the x-ray shows that the parents think you're smart. Foot tends to be flat. So the first step of this is get them a cushioned arch support. Try to lift that arch off the ground, take the pressure off. If it doesn't work, these kids do great with surgery. The key thing with the surgery is before the surgery, you have a painful flat foot with an accessory navicular. After the surgery, you have a painless flat foot. Doesn't fix the flat foot. If the flat foot is a problem, it needs separate surgery. So that's important to know. All right. Rigid feet are not normal, okay? So you worry it's either some sort of neurologic problem or it's a tarsal coalition, right? Tarsal coalitions. So there's abnormal connections between two or more bones in the foot. It's fairly common, and it's thought as the foot is forming, it doesn't segment properly, all right? So it's likely inherited. This is Nievergert-Hillman syndrome, where you get multiple tarsal and carpal coalitions, so we know it can be hereditary, all right? These are the kids that come in, and if you have a kid that has multiple recurrent ankle sprains, think about this. They have pain over the sinus tarsi, which is this little soft area anterolateral to the fibula, and they have a rigid flat foot, which gets worse over time. When they start out, they're cartilaginous between the bones, the connection is, and then they slowly ossify. So the foot gets stiffer with age. So it won't bother them when it's flexible cartilage when they're young. As they get into adolescence, it gets stiffer, and that's when they start having pain. All right. There's decreased subtalar motion. All right. If you try to swing the foot in, their peroneal tendons will spasm. Okay. When they stand up on their toes, you don't get that nice reconstitution of the arch. And a trick that the old retired orthopedist taught me when I was a fellow is ask them to walk on the sides of their foot. All right? They can't do it. It's very difficult to do. So we get an X-ray. This should be a big hole, and you can see there's a connection. There's a little bit of cartilage, and there's a bridge. That's a calcaneo-navicular coalition. Now, half of the time, these are bilateral. All right? This is easily to see. The less common talocalcaneo coalition is missed often on an X-ray, and you only see it on a CAT scan. So if you only see this, or you look at the foot and go, man, that's a rigid foot, that's got to be a tarsal coalition, and there's nothing, it may be talocalcaneo, and the CAT scan is the best way to see that. All right? So we try, believe it or not, we try not to operate on everybody. We try casting and boots and activity modification, et cetera. They all feel better in the boot of the cast, and they all have pain resume immediately when the cast stops. So most of these kids, if they're coming to you or coming to me, it's because they're painful, and so they get surgery. And so the calcaneo-navicular, that's easy. Those are two bones that are never supposed to touch. So we make our incision, there's the bridge, we resect the whole thing, we stuff fat into it or muscle. I like to use fat. It's funny, every mom, every patient says, do you need a donor? So they like that. So the fat gets in there and prevents it from coming back, all right? So this kid is a lacrosse player at Moses Brown. He showed up, you know, he had this coalition. You see it's mostly cartilaginous. You see it better on the CAT scan. You see when he's sleeping how the left foot just drifts into inversion, and the right foot, even asleep under anesthesia, is still rigid. All right, so you can see how deep this is. This is dorsal, this is plantar. This is the width of the coalition, and this is 3 centimeters, so it's very, very deep down there. And this is the fat. We take it from the butt, make a little incision in the natal crease, and it's invisible. There's no scar. It's very nice. And there's so much globular fat there, it prevents it from healing and reforming. And then you make a big hole, and they do very well. Now the other one, this is a talocalcaneo. This is the talus here, calcaneus. Here's the posterior part of the joint. There's the FHL tendon. This instrument is in the anterior joint, and if you look carefully, this white line is the cartilaginous connection. This should be a space. So we take that out, and we take fat either from the butt or right behind the Achilles. There's some fat too. All right. So the kids with the calcaneo-navicular coalition, those bones should never touch ever. So when you detach them, they do great, 90-something%. The talocalcaneal, there are 3 aspects to the talocalcaneal joint, an anterior, middle, and posterior facet. And unfortunately, when you remove the coalition, you're removing what should be a normal joint. So the results of that are not as good. And if they're older, or if it's a big coalition, or their ankle or foot is very tilted, often you really should do a fusion, which obviously long-term is not a great thing. So the results of this are good, but not as good as the other kind. Okay? And again, for a giant coalition, or if you've done it and they failed, fusion is required. Okay, and then lastly, we'll talk about cavus feet. And cavus, you know, I always thought of it as a big cave under the foot. It's a high arched foot. And it's an abnormal elevation of the longitudinal arch. Usually, it has a neurogenic origin, okay? Like this kid came to me with recurrent ankle sprains from an orthopedist in South County, and for ankle sprain surgery, we sent him to, you can see these kind of skinny calves and this high arch, so he has CMT. And so you got to look for that. And it may be subtle. Very functional kid, athlete. You would never think he has a neurodegenerative disorder, but he did. So it can be just a high arch, and we see this in families. They just have a high arch. Or it can be a Cavovarus foot or a Cavus foot. So in the high arch foot, you see clawing of the toes and a very high arch. In a varus foot, the heel actually swings in, and this is more common in my experience. So it's from a muscle imbalance. It could be from a residual deformity from a clubfoot. You can get a compartment syndrome with contracture. So they've been in a trauma and they broke their leg and they had surgery and no one realized they had a foot compartment syndrome. And then 6 months later, all of a sudden they can develop. It can be a nerve injury, or it could be idiopathic. So these patients often have ankle sprains. If they have the varus foot, they walk on the side of their foot, and that hurts. They have a big callus there and they have pain. If they just have a straight Cavus foot, instead of distributing the force, they're walking on their heels and their metatarsal head, so they have metatarsalgia. And if they have a lot of clawing, they'll have shoe wear difficulties. All right? So we can start with wide toe box shoes. You know, kids today love those big, you know, Frankenstein orthopedic shoes. But if that doesn't get better, we do surgery. So surgery, we have to balance the soft tissue. So for example, Charcot-Marie tooth, you have some tendons that are weak, some are strong, so you have to transfer and move them around to balance them. Rigid deformities, we actually have to cut the bones and realign them. And in a really bad deformity, we just reposition the foot and fuse it in place. And we make that decision based on the age, how passively correctable or actively correctable the foot is, where their strength is, and why do they have it. Is it from a peroneal nerve injury, from someone got cut with a piece of glass? Well, that's not going to change. Is it from CMT? Well, that's going to get worse over time, and you have to take that into account. So, Cavus feet, number 1, 2, and 10 in your list is figure out why they have Cavus feet. And early referral is good. You know, a few months ago, I saw 3 kids in a week and operated on all of them. Little kids with just a high arch, you can release their plantar fascia, stretch them, and cast them, or do a tendon transfer and maybe avoid bony surgery later. So if you see that, it's a good idea to send it down. All right, and that's it. Thanks.